let's kick it off. So thank you all so much for being here. This is the first session of the Policy Institute's Medicaid Summer School. The goal here is to use the summer to dig into some of the nitty-gritty Medicaid policy stuff that often gets lost in the shuffle during legislative session, during the fall and the spring, and to sort of give people a real grounding in how Medicaid works, what the scale and scope of the program is, and prepare us all to sort of advocate for the healthcare system we deserve in New York State. My name is Michael Kanuka, I'm the Health Policy Director at FPI. And let's start with some housekeeping. I see someone already asked. Slides and recordings of this class will be shared. We're doing a weekly class the next 4 weeks. So this is session 1 of 4, every Wednesday at 7. And we will send out the slides after the class, and we will also send out a recording. The organization of the class today is going to be sort of the least technical, most general introduction to how Medicaid works, specifically as a health insurance program, as opposed to all the other things it does. In future sessions, we're going to cover long-term care, which is a very in the news and very large part of what Medicaid does. We're going to talk about some important Medicaid esoterica, like the 1115 waiver, provider taxes, and how Medicaid supports safety net hospitals. And then in session 4, we're going to talk more about the future of Medicaid New York as HR1 impacts our system, but also as healthcare gets more and more expensive in the private sector. This is the first class format that FPI has done in recent memory, and it's a bit of an experiment for us. We want to make it as useful as possible to advocates, to policymakers, and to all of you. And so we really, really welcome and encourage feedback after the first session at any point. If there's stuff you want to hear more of, if I lost you, or if it was too basic, please shoot me an email and let me know what you thought. All right. So in this session, we're just going to talk about why study Medicaid at all. We're going to give a brief overview of Medicaid, and then we're going to talk about Medicaid enrollment and spending in New York State. And finally, we're going to talk about the largest by enrollment Medicaid program in the state, which is mainstream managed care. That's the program that provides health insurance to 5 million New Yorkers, and how it works. That's 25% of the state. So how it works really shapes how health insurance works in the state. But let's start with why we're all here, which is the question is why study Medicaid, right? And why study Medicaid as New York State-based, policy and politics people. And really, I love Medicaid for many reasons. It's my guiding passion. But to make the argument to anyone else, what I would just point out is that Medicaid is enormous. It is a huge part of what the state government does, right? So the graph here is of all funds spending in fiscal year 2027 for New York State. So we passed a state budget quite late, about a month ago, that spent a total of $277 billion in all funds spending. So that incorporates both state revenue and the federal aid that the state gets. And of that all funds spending, you can see Medicaid and Child Health Plus alone accounted for $123 billion of that $277 billion budget. If you incorporate the essential plan, that gets us to another $11 billion. And just those two programs combined are about half of the state budget. I give, for comparison, the state spends on public schools through school aid less than $40 billion. And everything else the state does, the state troopers, the state parks, all the other agencies are 102 billion, so less than Medicaid by itself. So it's a huge part of state politics. And it's also a really, really big, important part of our healthcare system. So this is November 2025 administrative data on health insurance coverage in New York. You can see that just Medicaid is it and CHIP account for 25% of total health insurance coverage in New York State. You add on the essential plan and you're up to in the 35% range. You can see those combined cover many more people than Medicare, which is less than 4 million people. And between Medicare, Medicaid, Child Health Plus, and the Essential Plan, we're talking about covering more than half of the state's population. So everyone else, the uninsured people on employer-sponsored insurance, everyone else is that 9 million, and the right side of this pie chart is public programs. So Medicaid is huge. Medicaid, CHIP, and the Essential Plan provide health insurance coverage to about a third of New Yorkers. They account for 49% of all funds New York State spending. They provide long-term care to 500,000 elderly and disabled New Yorkers. They provide Medicare supplemental coverage. They help Medicare enrollees pay copays and premiums for over 1 million New Yorkers. So that means that actually here in New York, about a quarter of all Medicare enrollees are also on Medicaid. We're going to talk about that more a bit later. And it's also a really, really huge economic force in the state, as you'd expect, given the scale of the spending. Medicaid is a key source of funding for nursing homes and hospitals that are often major employers all across the state. And then it also sets the working conditions for our long-term care workforce, which is about 600,000 people. That's the largest single occupational category in New York. So Medicaid home care workers, there are more of them than fast food and retail workers combined. They're a huge part of our economy. So that's why I study Medicaid, which you all knew. That's why you're here on a Wednesday night. But of course, we wouldn't be here if Medicaid weren't also a very complicated collection of programs. And I think it's really, really important, just as level setting for the rest of this class, to think it's not really useful to think of Medicaid as a single program that provides, let's say, health insurance or whatever else. Really, you need to think of Medicaid as at least 5 distinct state programs, each of which is really large and significant. So first of all, when people, talk about Medicaid, when they're at the level, they're no longer confusing it with Medicare. They know it's a distinct thing. We think of it as a health insurance program, and it is. It's a health insurance program for about 25% of the state's population, even more if you count the essential plan. But that health insurance program that covers 25% of the population is actually less than half of the Medicaid budget. So that's less than half of everything Medicaid does. Another very important and very expensive thing that Medicaid does is it provides long-term care to people who are also on Medicare, right? So folks in this category are called dual eligibles because they're eligible for both Medicare and Medicaid because, Congress created a program for the poor and a program for the old, but some people are both poor and old, and especially if you need long-term care, a nursing home bed in New York State costs about $120,000 a year. So if you need long-term care, you're liable to need help paying for it very quickly. A huge part of what Medicaid does is provide long-term care, help with bathing, eating, getting dressed, that kind of thing for elderly and disabled people across the state. Medicaid is also the program that provides care for people with intellectual and developmental disabilities. It provides everything from employment supports to supervision to funds the group homes, everything else. And importantly, we're now on the 4th, sub-program within Medicaid. There's a program called the Medicare Savings Program in New York that helps low-income seniors who don't necessarily need long-term care, but they just need help paying for Medicare. I don't know what the average age on this webinar is, but when you get to be 65 and get on Medicare, you'll often be sort of very negatively surprised by how expensive Medicare can be. Medicare requires a premium. You have to pay for drug coverage. You have to pay copays. About 1 million folks on Medicare in New York State out of the roughly 4 million who are on Medicare need help with all of that stuff. And so they're enrolled in the Medicare Savings Program. And finally, Medicaid is a major funder for safety net hospitals, even outside of just paying for hospital care. It also directs funding specifically to hospitals that serve low-income people and would close without Medicaid. We're going to talk a lot about that in a future session. So these 5 programs are a huge, huge part of the state budget. So how did we get here? It's a bit of a strange thing, right? In the US, most of the big social programs, Medicare, Social Security, are run by the federal government, but this one is left up to each state to administer. So let's talk about sort of how we got here and what the sort of background is, that is. Usually, I think what you would get an A for saying in high school history about this is that in 1965, under Lyndon Johnson, Congress created 2 health insurance programs, Medicare to provide health insurance for the elderly and Medicaid to provide health insurance to the poor. That's, mostly right, not totally wrong, but it's a little more complicated than that. Because Medicare really is Congress stepping up and creating a health insurance program. You're eligible if you're over 65, if you have certain categories of disability, if you have end-stage renal disease, you can be on Medicare. And then Medicaid is something a little bit different. So what Congress did was it said states had the responsibility for administering welfare and assistance to the aged, blind, and disabled. And, that stuff was running through state and even county government. The federal government had begun with the Social Security Act to subsidize states in doing some of that, in some of that spending on, basically welfare, right? And over time, even before the passage of Medicaid, it emerged that a lot of folks on welfare who are that low income couldn't afford health insurance. The federal government offered to essentially subsidize or match the spending that states were doing on healthcare for people who are on sort of state level welfare. And so the dynamic here, right, is that the state runs the program. It makes the basic decisions about the program. It's overseen by folks working for state government. And then the federal government, if the state runs a program that is that meets certain requirements, will match that spending. So Congress did not require every state to offer Medicaid. In fact, New York and California, as you would expect, were right off the mark, immediately set up Medicaid programs. But some more conservative states actually didn't set up Medicaid programs for a while, wanted to see how things would play out. Arizona didn't start having a Medicaid program until 1987. But if the state offers, if a state sets up a Medicaid program, which now every state has, the federal government will match state spending on it. So if the state spends $1, the federal government will kick in between $1 and $3. So the amount of match depends on what category of spending, but especially it depends on what state you're in, because Congress decided to help poor states more than rich states. So in New York, the match for most spending is 50%. But in poorer states like Mississippi and Louisiana, it can be as high as 75%. So when we talk about like if the anytime we're talking about Medicaid spending, we have to know whether we're talking about sort of the total spending or just the spending that the state picks up. So for instance, sometimes people will say like, New York State passed a budget with, 37 or 40 billion dollars in Medicaid spending, referring specifically to the state share of that spending. But um, but that spending is also matched by the federal government. So there's another, 40 or 50 or 60 billion dollars coming from the federal government. All of that spending is overseen by the state. Mm. Now, from that story, the sense you get, right, is Medicaid was initially really, really closely linked to cash welfare, right? So the idea was there are some folks receiving aid for families with dependent children or other kinds of cash welfare, um, sort of state federal aid for the blind and disabled, stuff like that. If you're in that category and you're receiving that welfare, then Medicaid will also pay for your health insurance. That's how Medicaid started. New York always had bigger ambitions for the program. New York actually tried to make set eligibility levels that were much, much more generous, and Congress had to come back, and rein us back in. But New York turned out to be really visionary because over time, Medicaid has sort of expanded, even as welfare has been cut and was cut under the Clinton administration. Medicaid has kept growing because it serves really important needs for health insurance and for long-term care, and has gradually sort of left its tight link to welfare per se and become a general purpose health insurance program for anyone who's low income, doesn't have other sources of insurance. And so that process, that historical arc, sort of takes the form of every couple years. Congress will come in and say, we're going to give states the option of covering, pregnant women up to 200% of the federal poverty line, or foster children up to 170% of the poverty line, gradually sort of expanding the different categories of eligibility. But that process really culminated in the Affordable Care Act of 2010, which dramatically expanded Medicaid by just sort of saying, we're going to do a straight up income test. If you earn less than 138% of the federal poverty line, which is about $22,000 for an individual, 45-ish thousand dollars for a family of four, then you can be on Medicaid. And then there's the other side of the Medicaid story, which is long-term care. In addition to providing health insurance for low-income people, Medicaid also provides long-term care for mostly people who are getting their health insurance from Medicare because they're old, elderly, or disabled, and they qualify for Medicare. Medicare does not pay for nursing homes or home care. It does not pay for long-term care. It pays for, rehabilitation after a surgery, that kind of thing. But if you're sort of permanently or in the long term disabled and you need help getting out of bed, getting dressed, using the bathroom, Medicare does not pay for that, which is sort of a strange policy oversight. But Congress did not understand that as a major problem for elderly people when it was enacting Medicare. And so it kind of got left as an afterthought and wound up on Medicaid's budget and books. This is one of these very very unexpected policy impacts. Is like when people were working in Congress in 1965 to pass Medicaid, they just as an afterthought threw in, oh yeah, like states can also use this funding stream to fund nursing home care. and over they did not realize how big a need that was, and almost overnight that river of federal money started flowing, and very, very quickly nursing home care and later home care became about half of all Medicaid spending. So it's a huge portion of what the program does, and we're going to have a full session on it next week. Um, I always think it's really interesting to compare Medicare and Medicaid. I think that there's something I was taught in college in a policy class, and that you hear a lot is that, programs for poor people are poor programs. That like sort of Medicare is this middle class universal benefit that everyone gets, and so it's politically protected. People love it, and it works well. Whereas like Medicaid, oh, it's for poor people. It doesn't have as much of a constituency, all this stuff. But if you compare Medicare and Medicaid, you can see Medicaid has actually, in many ways, been the politically stronger program. It has expanded to cover new benefits pretty quickly. So, for instance, Medicare only got a prescription drug benefit in 2005, but in many states, Medicaid started covering prescription drugs much sooner. It has also expanded. I mean, really, Medicaid has kept adding eligibility categories up to 2010, whereas the last time Medicare expanded was in 1972 to cover people with end-stage renal disease. So, and Medicaid to this day, it provides much more comprehensive coverage. Copays tend to be low or zero. There's no premium. Whereas Medicare, you have to pay a premium and a copay and so forth. And so, in some ways, there's a joke among health policy wonks that when people say Medicare for all, if they're thinking of like totally free insurance that covers everything, they must be thinking of Medicaid, not Medicare. That said, Medicaid does have at least one serious restriction, which is that it tends to pay lower rates to providers than Medicare. And that results in, if you pay lower rates to providers, some providers just won't be interested in serving Medicaid patients. And so that's led to consistent sort of lack of choice and options in provider networks in Medicaid. So that's on the minus side. I want to talk a little bit about the sort of dynamics of the state-federal Medicaid relationship, which is, like I said, so the state administers the program. If the state administers a program that meets federal guidelines, then the federal government will provide matching funds. And the the guidelines the federal government provides are really substantive. There's a significant amount of federal oversight. And, states have to meet a whole list of specific requirements, ensuring that they sort of provide a minimum level of benefit, that they offer it on equal terms to everyone in the state, that they allow providers to participate if they want, they don't discriminate among providers. And each state needs a state plan that's approved by the federal government. And if they want to, which is a written document in, New York State's, you can find online. It's about 4,000 pages at this point. And if they want to change anything about the program, they have to amend that state plan, get federal approval. There's a little bit of a tension or conflict between states and the federal government here that's going to come up throughout this class, which is that the federal government now is run by somethings, but even generally, no matter what administration you're in, the state always has an incentive to sort of get as much of a federal match as possible by categorizing as many things as Medicaid spending as possible. And so, I heard someone joke recently that New York historically has, quote, used Medicaid as a verb. So what that means is like you're looking at a program that provides, care, some kind of care or supervision for companionship for people with dementia or something like that, and you think, oh man, could we recategorize that as Medicaid spending and get the federal match on it, right? Like that kind of thing is always where the states are pushing. And then the federal government is always pushing back and saying, no, 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 Medicaid is, this limited set of things. Um, let's see. We're going to talk a lot more about waivers in class 3, so I just want to briefly touch on them. Because there's this elaborate federal regulation, sometimes when a state wants to do something creative or innovative, good or bad, with its Medicaid program, it finds that it actually is sort of in violation of federal rules. So, like, let's say, there's a state is trying to deal with the AIDS crisis and it wants to provide a special set of services, care coordination, support to specifically people living with AIDS to better care for them. But then the black letter of the federal law says, well, you can't just offer some benefits to some people, but not others. You have to offer everything to everyone. The state can apply to the federal government for a waiver of that kind of requirement and say, we want to do things differently for this specific population. We promise it won't cost you more. We promise we're going to still be fair to everyone. And then the federal government can choose whether to waive the rules for them or not, usually in sort of a time delimited fashion. So they'll waive the rules for 5 years and let the state do what it wants. This started as like a sort of minor corner of the Medicaid program. There weren't that many waivers at the beginning, and they were fairly narrow. But today, actually, huge portions of every state's Medicaid program are run on the basis of waivers. There are like 500 active waivers in the country, so more than one for each state, many more than one for each state. New York has, I think, 4 active waivers now, and many states have even more than that. And a lot of the sort of state-federal negotiation that happens through the federal government deciding whether to approve these waivers or not. So that's sort of a guide generally to Medicaid. It's a huge program. It's state, federal. The two big things it does are health insurance and long-term care. And it also does a bunch of small things. And now I want to talk a little bit about the state of New York State's Medicaid program in 2026 as we sort of approach federal cuts. And so the first question we should ask is, how many people are on Medicaid New York, right? I said that it insured a quarter of the state's population and more if you count the essential plan. Now I'm going to say sort of where do those totals come from and how do we work it out if you add up all of the different programs? This slide is a bit of a joke, but it's actually very hard to figure out how many people are on Medicaid in New York because Medicaid means so many different things. So I'll start with the wrong answers. The enacted state budget that we just passed says that 6.5 million New Yorkers are on Medicaid, and if you combine that with CHIP and the essential plan, it's up to 8.7 million New Yorkers enrolled. So this makes it sound like almost 40% of the state is on Medicaid, which is getting their health insurance through Medicaid, which is seems high to a lot of people. I think that's why the state, the executive budget sort of emphasizes it to say, New York's Medicaid enrollment is out of control. But I would say it's misleading. Right. So because again, we have to distinguish, what are we talking about here? Are we talking about health insurance? Are we talking about long-term care? the Medicare Savings Program, um, and even the executive budget or the enacted budget counts some emergency Medicaid registrants who are their own category of things. So we have to sort of pick this apart to get a good definition. Um, uh, so I have dug into this and come up with somewhat lower numbers. So I would say, using May 2026 data, the right answer is what you see before you, that the folks getting health insurance through Medicaid and through similar programs, if we think of health insurance as, they're not on Medicare, they're not on an employer-sponsored insurance, they have an insurance card they use to go to the doctor or the hospital, and that insurance card is from Medicaid. The right answer of sort of Medicaid enrollment, strictly Medicaid enrollment, is about 4.4 million. If you add in Child Health Plus, which is a very similar sort of state federal program that provides health insurance specifically for children, we get up to about 5 million because there are about, it's 523,000 folks on Child Health Plus. And then if you add in the essential plan, which I would say we should talk about the essential plan separately, because it's not really Medicaid. But even if you stretch the definition, you say, let's include the essential plan, we get up to about 6.6 million people sort of getting their health insurance through these various state programs. And so where is the enacted budget sort of 8.7 million coming from? Well, they're adding in dual eligibles on the Medicare Savings Program, which is about 1.2 million people. Folks get on Medicare who are getting long-term care, which is about 500,000. And then an unclear additional million people, which seems to be sort of a data error on the state's part. I will talk about emergency Medicaid at some future point, but really by rights, I think the right way to look at it is that there are about 7 million, 7.5 million people on Medicaid, of whom 6.6 million are really getting health insurance, and the other 1 million-ish are either getting both long-term care and the Medicare Savings Program, or just the Medicare Savings Program. So sorry to get in the weeds there, but I think it's helpful to really highlight two numbers. The sort of 5 million on Medicaid proper and the 6.6 million on Medicaid plus the essential plan. Those are the folks getting health insurance from New York, and that's about a third of the state. So this is another breakdown of this. We don't need to sort of work through these numbers in detail, but broadly speaking, the thing I like to point out is this is sort of different kinds of public programs and state administered programs, and their March 2026 enrollment. So we can see Medicare is about 4 million, Medicaid proper is about 5 million. The essential plan adds another 1.7, and then there are about almost 1 million people on the individual market or the small group market, both of which are administered by the state. And so between the federal Medicare program and all these state administered programs, we're talking about 58% of the state being on some kind of public or state administered insurance program. And I think that's really important to talk about because we tend to think of public insurance as what happens when you can't get private insurance, as sort of a safety net or an afterthought. But in fact, increasingly sort of private employer-sponsored insurance that isn't administered by the state is a shrinking section of the pie as public programs grow. So just to think about. So let's talk about Medicaid spending, because Medicaid spending is really what tends to get the program in the news and in trouble. Um, and it's when we talk about Medicaid spending that it's really important to think about Medicaid health insurance on the one hand and Medicaid long-term care on the other, because most of the enrollment in the program is in Medicaid health insurance, but most of the spending is actually happening in long-term care. And the easiest way to get a picture of this is just to look at sort of the average spending per member per year on in New York State. These are figures from New York State Department of Health in each enrollment category. So if we start with sort of non-disabled adults, to put a non-disabled adult on Medicaid costs on average about $5,800 a year. And as we'll talk about, that's a surprisingly cheap number for health insurance. It's much, much cheaper than private insurance. Children are even cheaper to put on Medicaid. It's about $4,300 a year per child. That makes sense because children tend to have less chronic health conditions. They're less expensive. And then there's the elderly and disabled populations on Medicaid. Again, these are folks who are mostly getting their health insurance from Medicare. They're getting their long-term care from Medicaid. And so just the long-term care benefit for elderly and disabled Medicaid beneficiaries is over $40,000 per enrollee per year. So almost 10 times the cost for the sort of non-disabled population. And so I'm using this pie chart to communicate that. The left-hand pie chart is share of enrollment, and you can see that the vast majority of people who are on Medicaid are not either elderly or disabled. They're adults or children who don't have a major disability, right? But if you look at spending and you split things by spending, then almost 60% of the spending in New York State's Medicaid program actually goes to elderly and disabled New Yorkers, with 40% going to everyone else. And so just to sort of put this in numbers, the most recent data I could find that sort of sliced things this way, which was from the federal MacPac data in 2023. MacPac, is the Medicaid and CHIP Advisory Commission. It's a committee of experts convened by the federal government that puts out Medicaid data and recommendations every year or so. And what it showed was in 2023, New York spent $94 billion in total on Medicaid. It used that to insure 6.6 million people. This was right after the pandemic, so enrollment was a little higher. And those 6.6 million people accounted for $39 billion worth of spending. So significantly less than half of total spending. On the other side, the much smaller group of about 1.5 million elderly and disabled New Yorkers, and especially the subgroup of those with the about 500,000 people with major physical or mental disabilities, cost $55 billion to care for. And so the spending is really, really tilted toward long-term care. What that means is that if you want to sort of think about trends in Medicaid spending, so you can sort of say like, okay, enrollment went from 5 million to 6 million. Did that raise spending? But if you're not looking at who the new enrollees are, then you're not capturing the spending because each additional elderly or disabled enrollee is going to cost almost 10 times as much as each additional non-elderly or non-disabled enrollee. So the spending is really, really tilted on that side of the program. In fact, Medicaid, the health insurance part of Medicaid, the non-long-term care part of Medicaid is actually shockingly cheap. And so this graph compares a New York State employer-sponsored insurance premium for a single individual. So that's like if you're like I am, I work a job and I get health insurance through my job, and my employer pays for some of it and I pay for the rest of it. But if you combine those two payments and say, what does it cost in total to insure me as a single individual on private health insurance? The answer is $9,600. So it's very, very expensive. It's a large share of your compensation. But if you compare that to what it costs to insure a single adult on Medicaid, Medicaid is much, much cheaper. So it's about, compared to 9,600, it's about 5,800 to insure an adult on Medicaid. And that's really important to keep in mind. Medicaid is actually like a really efficient way to provide health insurance to people. Um, and so how and one policy implication of this is if we just let employers buy Medicaid instead of private insurance, they would be much better off because they would save, $4,000 a year per person just by being able to buy into Medicaid. And so the question is, why is Medicaid so cheap? Which is not often a question asked in Albany, right? There's a lot of questions of like, why do we spend so much on Medicaid? But here we are sort of trying to figure out why it's so cheap. And, the basic answer there is most health insurance spending, even though it passes through the hands of a health insurer, both in the private sector and in Medicaid, as we'll talk to, it goes to healthcare services, right? So it goes to pay doctors, hospitals, drug companies, and especially it especially goes to pay for care for the sick, right? So if you're a healthy adult who goes for a checkup once a year, you're not spending that much money. But if you have a chronic condition or if you get hit by a car and end up in the ICU, then you're gonna cost a lot in health insurance. And and so most of the spending in Medicaid and in commercial insurance goes to pay for healthcare services, and Medicaid just pays a lot less than other payers, less than commercial insurance and less than Medicare for all of that stuff, for doctors, hospitals, drugs. And it's important to sort of stack that up, like how much less. And so in 2024, New York State paid, Medicaid paid about three-quarters as much as Medicare for doctor's visits, which was up a little bit in recent years from, and it's hard to do an apples to apples comparison with hospitals, but Medicaid also pays about what Medicare pays for hospital care. But commercial insurance pays 2 to 3 times what Medicare pays for the same services at the same doctor's offices, the same hospitals. So the big difference is really price, and that's where the comparison happens. Um, But just to say it, right? So that there's no mystery why Medicaid is saving money. On the other hand, it is a very, very cheap way to provide health insurance, and really, it's the cheapest way that we have as a society to provide health insurance. It isn't. I think there's a perception that New York's Medicaid spending is out of control. But if you look at this graph, you start to think, no, it's actually private insurance that's out of control. New York State Medicaid has sort of held down costs for the millions and millions of people for whom it provides health insurance. Um, and and that's an important thing to keep in mind as we sort of consider policy options for the state to preserve and expand coverage and get to universal coverage. So I think there's some folks in state government and even more people in the Trump administration who really think like, wouldn't it, why are all these people on Medicaid for health insurance? Wouldn't it be better if they got health insurance through an employer? And there are two problems with that. First of all, they're not going to get health insurance through an employer because the employer would need to pay almost $10,000 per person per year to insure them. And the kind of employer who tends to employ low income people, often close to the minimum wage, is not going to pony up $10,000 to provide them with health insurance. So first of all, there's a problem, which is that it won't happen. But even if it did happen, it would actually really increase the total cost of healthcare in the state, right? Because we have a way to save to provide health insurance that is the most efficient way we can, and Medicaid is it. So we've talked about, again, Medicaid is two programs. We got the health insurance side. The big news on the health insurance side is that health insurance under Medicaid is surprisingly cheap. And then we've got the long-term care side, where I said earlier that the average cost of putting an elderly or disabled person on Medicaid is in New York State is $42,000 a year. And so, it's a really, really significant amount of spending. That averages across a lot of people who are not mostly disabled and are mostly just getting Medicare Savings Program support, paying for Medicare premiums and copays. And so if you actually focus in on the population that needs long-term care, it's even more expensive than that. We're talking $50,000, $55,000, $60,000 per year. And there's been a lot of policy concern around this. And so I want to just talk a little bit about why is it so expensive, and whether we should be concerned about it. The shortest answer here is it's expensive because long-term care is very expensive. So long-term care refers to support with activities of daily living, like eating, bathing, dressing, for people who have a physical disability that doesn't allow them to sort of live in their house on their own, right, without some hands-on support. And so, if someone is frail enough that they can't eat or use the bathroom by themselves without assistance, then they can't really be left at home alone very much, right? And they might need 80 hours a week of home care, which is, two full-time equivalents worth of home care workers coming to their house, providing that one-on-one care, even at low wages, right? And home care workers definitely make poverty wages. That's still, we're talking about $80,000 a year right there. And so long-term care is expensive because it is enormously labor intensive. It can't be automated. You have to be there one-on-one providing that care. The other thing I'd say is Medicaid long-term care is not insurance, right? So the way insurance works is that you insure an entire population. Some of them are sick, most of them are healthy. So when we talk about Medicaid health insurance costing $5,800 a year, what we mean is, most of the people who are on it are healthy. They get an annual checkup. That's it. They're probably costing the system, $200 a year, practically nothing. And a few people get hit by a car, they get cancer, and they're costing hundreds of thousands of dollars. But the average between those two things is $5,800 a year. With Medicaid long-term care, that's a very different situation because people come to apply to Medicaid because they need long-term care. And so everyone entering these programs is someone who does need an intensive amount of services. So it really makes sense between these two things that it is quite expensive. So, the next thing I want to talk about with the Medicaid budget is sort of is New York spending too much on Medicaid? So, there are two ways to sort of cut this, right? If we want to compare New York spending to other states' spending, New York spends the fourth most per enrollee on Medicaid of any state. So that means if you sort of take the total spending, divide it by the number of people on Medicaid, we spend almost $13,000 per person per year on Medicaid. We now know that that averages in many people getting health insurance who cost far less than $13,000 a year, and a much smaller group of people receiving long-term care who cost much more. Um, that is more than the average state significantly, but it is not sort of it's not a wild outlier relative to the average state. So if you look at the list of states sort of sorted by per enrollee spending, you see a bunch of blue states with high costs of living spending a lot. It sort of makes sense. Healthcare workers get paid more here, things are more expensive, and we're on that list. Um, and we're also not the top, we're the fourth highest. But if you cut things a slightly different way and you ask, how much does New York spend per state resident on Medicaid? So sort of how much are we spending per person? If you take the Medicaid budget divided by 20 million New Yorkers, what is each of our sort of notional share of that? The answer is New York really stands out. It spends the most on Medicaid per state resident of any state in the country, and by quite a bit, right? So Kentucky is in second place, and it spends, almost 4,000. We spend almost 5,000. And so there's a question of just, why is that? What is the sort of New York specific thing that we're doing that's causing that spending? And the answer is actually pretty straightforward. And as we'd expect, given the discussion so far, it's all about long-term care spending, right? We actually we don't have too many more people on Medicaid health insurance, and we don't spend that much taking care of them. We're actually below national average in some of that spending. So it's not the health insurance side, it's all about the long-term care side. And the answer is basically we have a larger share of our population on Medicaid, of our elderly population on Medicaid, and we spend more per person than the state average. So nationally, about 15% of seniors are on Medicaid, but in New York, it's about 25%. That's not the highest in the country. It's like top five or something like that, but not the highest. And nationally, Medicaid spends about $25,000 per dual eligible enrollee. We spend more than that, $35,000. Again, that's high, but we're actually behind North Dakota. But if you combine these two things, you say, okay, we have a lot of people on long-term care Medicaid, and we also spend a lot on each of them, then that is sort of the difference that drives New York State Medicaid spending. Um, and so sort of why is this? Basically, New York State, relative to the rest of the country, not relative to how I think things should work, but relative to the rest of the country, has relatively generous eligibility for the elderly and disabled who want to get on Medicaid. Generous eligibility means the the set of tests you have to pass to get onto Medicaid, income tests, asset tests, and sort of tests of your ability are relatively less restrictive in New York than in other states. So, for instance, in many other states, a elderly person who needs long-term care may need to spend down their life savings before they can access that care. In New York, we've set things up so that you mostly don't need to do that or don't need to do that as much. We have a less restrictive asset test. And similarly with income test. And then we also have relatively generous benefits for those who are enrolled in Medicaid. So unlike in other states, they don't face wait lists. There aren't hard caps on the number of home care hours they can get. And so if you combine those two things, we're running a large long-term care system, and that's sort of driving our uniqueness relative to the rest of the country. And it that system has grown quite a bit in the past few years, which is really sort of what's driving the bus on healthcare on Medicaid spending. Are we spending too much? That's a value judgment. We're going to talk a lot more about these issues next week when we do a full session on long-term care. So I'm going to actually save this discussion for that. But broadly speaking, what I'd say is long-term care is expensive. And what is unique about New York State is that we've decided to socialize so much of that spending to put it on the state budget. In many other states, the care that we pay for through Medicaid is basically provided for free by family members, by spouses. I joke that the US policy on long-term care is that female relatives will do it for free if you don't pay for it. In New York, we've made a policy decision in a really different direction, where we're saying, we don't think people should have to provide this care for free and people should have to rely on the charity of their relatives. We're going to move it onto the state budget. And that's really what's driving New York State Medicaid spending differences. So I'm going to talk a little bit about, what we've done so far is we've talked generally about enrollment, Medicaid enrollment levels and spending levels in New York and sort of how spending compares to national spending and why that is. Now I want to talk briefly about Medicaid as health insurance. So by that, I mean the program that provides a health insurance card so they can see the doctor for 5 million New Yorkers. And is what most people think when they think about Medicaid, even though, as we've seen, it actually accounts for less than half of the spending. It accounts for much, much more than half, like 80% of the enrollment in Medicaid. So let's talk about how that program works. So we've talked about sort of how many people are on Medicaid and CHIP, and statewide it's about 5 million. More than half of those people are New York City residents. Eligibility for sort of mainline health insurance Medicaid is a little complicated, but the basic rule is that anyone earning under 138% of the federal poverty level can be on Medicaid in New York for now. That's $22,000 a year for a single individual or $45,000 for a family of four. So it's really, really low income people. There are somewhat higher eligibility levels for certain specific categories: children, infants, pregnant women, foster children, stuff like that. But they're all in terms of that sort of percentage of poverty. I would love to know more about exactly who's on Medicaid, what the age ranges are, what the racial makeup is, but unfortunately, the state doesn't publish that data. But what we can say is that a huge chunk of total Medicaid enrollment is children. And the reason for that is actually pretty simple. It's that a lot of the poor people in the US and in New York are families, often single parent families with children, right? Like if you just think about the how the poverty line works. If someone earns $45,000 a year and they're a single mother of three or similar, um, then they wind up falling under the poverty threshold and on Medicaid. Um, so how does this health insurance program actually work? The big program that provides health insurance for 5 million people is called mainstream managed care. So within Medicaid, we have a bunch of different programs. In New York, the health insurance program is called mainstream managed care. And the reason for this is that it provides health Medicaid through managed care. So historically, this wasn't the case. The state paid doctors and hospitals directly for Medicaid services. But starting in the late 80s and fully since 1996, most health insurance Medicaid has operated under managed care. And so what that means is that the program is actually administered by private insurance companies. So the state pays an insurance company what's called a capitation rate, or sometimes it's called a per member per month payment, or a PMPM, for each enrollee who signs up with that insurance company. And then the insurance company is the one who goes out and sort of signs up a network of doctors and hospitals and actually pays for the healthcare. So in that sense, it's actually kind of similar to how employer-sponsored insurance works, right? Like when your employer pays for your healthcare, they don't directly pay doctors for doing surgery on you. They pay a monthly payment to an insurance company, and then the insurance company pays for everything. It pays for the actual healthcare services. And so just to emphasize, all of the 5 million people getting health insurance through mainstream managed care Medicaid and through the Child Health Plus program, they're all signed up with insurance companies which provide Medicaid plans, and the insurance companies pay for their care, manage their care, and are paid by the state monthly premium payment. And so why did the state decide to sort of introduce private sector, intermediaries into the system? There were various hopes when the system was rolled out in the late 80s to 1996. It was hoped that private companies could sort of manage and coordinate healthcare better, sort of making sure that healthcare was being delivered efficiently, that could save the state money. And then there was, I would say, I'm calling it neoliberalism on the slide. There was a broader sort of sense that the private sector could do better. Subject of future writings in FPI, I'm very skeptical that managed care has worked well for Medicaid, but it is how Medicaid works in New York State. And so this isn't like in the Medicare program, you have Medicare Advantage, which is similar, but enrollees get to choose whether to be in Medicare Advantage or traditional Medicare. In New York State, if you go to get Medicaid as health insurance, you have to sign up with an insurance company. And so I just sort of graphed the specific insurance companies that provide most of Medicaid in New York. The big ones are Fidelis, Health First, and Metro Plus. Fidelis is the local brand name of a national for-profit insurance company. Health First is a nonprofit. Metro Plus is actually owned by New York City Health and Hospitals. What's interesting about this chart is you do see the sort of big national insurance companies on here. You see Anthem, you see United, but a lot of the Medicaid managed care is sort of provided by Medicaid specialist insurance companies. So there's a whole wing of the insurance industry that's sort of focused on Medicaid, some nonprofit, some historically nonprofit, now for profit. Um, so, with that said, um, Medicaid as health insurance is, is in a way it's the most straightforward part of the program, especially now that it's administered by private insurance companies. When you enroll in Medicaid, you select one of these plans and you get a insurance card with their name on it. It has a network and so forth. The I want to talk very briefly about sort of current events and then move on to Q&A. As I've been saying this whole time, Medicaid is a huge part of the health insurance picture in New York. Just sort of Medicaid, not counting the essential plan, covers 25% of New Yorkers for their health care. Um, Federal legislation passed last summer, HR1 or the One Big Beautiful Bill Act, is threatens to really, really cut that back. And so uh, this undoes a lot of the work that New York State has done to cover people. New York has worked really well and long and hard to ensure that that it's easy to enroll in Medicaid and that the it's easy to stay enrolled. HR1 is going to make it much harder to enroll and to stay enrolled because folks will have to undergo burdensome work requirements to sort of prove that they're working or qualify for an exemption. They'll also have to recertify that they're still qualifying every 6 months instead of every year. This is likely to lead to really, really significant enrollment loss. Perhaps 500,000 to 800,000 people will be sort of off the Medicaid rolls due to this policy change. So we're at this really interesting moment where we will be seeing New York State Medicaid shrinking, and I want to sort of just get this chart in there to get a sense of where we are in the history here, because we've already lost a huge number of insured people this summer due to essential plan cuts. Now we're looking at Medicaid cuts. And what we can see in this chart is really the growth in New York's insurance rate due to the expansion of Medicaid after the passage of the ACA is about to go into reverse. So that's sort of the moment we are in New York State health insurance. So I want to move on to Q&A. Again, any feedback folks can provide over email will be really, really helpful as we sort of work to refine this format. But next week, same time, same place, we are going to be covering Medicaid long-term care. We're going to get much more into the nitty-gritty of how that works, where the money goes, and what sort of why it's grown so fast in recent years. But with that, I'm going to move to Q&A, and I'm going to start, as is only fair, with people who have already asked questions in the Q&A. I think I've covered some of these, but so one person asks, sort of relating to how Medicaid is a cheaper way to provide health insurance because it pays lower rates to providers. Should we think of that, this person asks, as is private insurance sort of subsidizing public insurance, which is a common way to think about this relationship. If you talk to like the hospital industry, they'll say Medicaid pays such low rates and Medicare pays really low rates, and the only way we can even stay in business is by charging commercial insurance really high rates. And so, sure, Medicaid looks cheap, but it's because commercial insurance is paying more. I think there's a more balanced way to look at it. I think right now we have a really enormous divergence between different payers in terms of the rates they pay, where Medicare and Medicaid uh, pay about the same, or Medicaid pays a little less, and then commercial insurance in New York pays 2 to 3 times as much. And those commercial insurance rates are really increasing very quickly. Um, I think rather than looking at it as private insurance subsidizing public insurance, I would say we have two wings of a dysfunctional system. We have Medicaid rates that are too low, and then we have commercial rates that are really expanding too quickly. And I think a sort of better, fairer health policy system would converge those rates, would regulate the commercial rates to bring them down, and invest more in Medicare and Medicaid to bring those rates up. Um, Someone asks about fee-for-service Medicaid. So this is important terminology that I should have covered. So basically, I described managed care Medicaid, which is the kind where the state pays an insurance company to administer the benefit. In the wonky terminology of healthcare policy, the opposite of managed care Medicaid is fee-for-service Medicaid. And that means the state is just directly paying hospitals, doctors, other providers. The vast majority of New York State Medicaid, both long-term care and health insurance Medicaid, is managed care now. This has been a long-standing policy trend for the past 30 years in New York. The remaining fee-for-service aspects are sort of the leftovers, or places where the hasn't reached yet. Some of that is like emergency Medicaid for people who aren't signed up for Medicaid, but they come through a hospital emergency room and sort of get on Medicaid that way. Some of their care will be paid for fee for service. There are a couple of small waiver programs for people with intellectual and developmental disabilities, and for people transitioning out of nursing homes that are fee for service. But most managed care is Medicaid. I do think that especially on the long-term care front, there is a chance that we will in coming years want to reconsider that, because managed care, especially in the long-term care side of Medicaid, has worked out really, really poorly for New York. But I'll have more to say about that next week. Someone asks, will we be discussing Medicaid work requirements at length in a future session? Yes, I'm planning to cover that in session 4 on sort of the future of Medicaid. And I obviously, for longtime followers of FPI, I've had a lot to say about those work requirements over the past 6 months. So my goal is to sort of give people the background and policy context, and then build up to where we are now. And so let's see. Someone asks, how good or bad are the health outcomes for people on Medicaid in New York? That I cannot speak to. The surveys suggest that people are quite satisfied with the care that they're getting. But I'm not up on the research of sort of, is it high quality? Someone asks a great question that I hope to do more research on soon, which is sort of the about the percentage of Medicaid services provided by hospitals versus sort of independent providers, independent maybe doctors versus hospital affiliated doctors, stuff like that, and how that impacts Medicaid costs. The big pattern in all over healthcare right now is that everything is sort of consolidating with, both insurance companies and doctors' offices, insurance companies and hospitals buying up independent physician practices. And the tendency is for that to raise costs. In fact, the reason hospitals and insurance companies do this is often because they want to raise costs and charge more. Unfortunately, the state doesn't release data on what that breakdown is in New York State Medicaid, but I do think it should be possible to extract some of that from some freedom of information requests I've been filing recently. So I hope to cover more of that in the future. Hmm. All right. So most of the other questions, I think we've covered. So unless anyone has sort of a final question, I think we can call it good for this evening. And I really look forward to meeting with you all next Wednesday at 7 p.m. to discuss Medicaid long-term care, which should get us a little bit more in the weeds. Thank you all so much.